other issues as well. Let me get that because I think you're all seeing. There we go. So the truth is that our well-being as nurses, as healthcare providers, doesn't just affect us and the people that care about us, about our people, our tribe, our people, our families. It also affects the quality of care we provide, the experience of the people that we care for, of our patients, and ultimately the bottom line of healthcare organizations. Nursing researchers, specifically Linda Aiken's team at the University of Pennsylvania, have really been the pioneers of studying this field, building this empirical evidence for the relationship between the provider well-being and patient outcomes. And a lot of the history behind this is because as we've had these nurse shortages, since the 80s, there's been this focus on how do we retain the midwifery. Sorry, I apologize. I meant to say that I spend a lot of time in the world of midwives. And so I tend to default to the word midwife. And I'm not trying to be inclusive, not exclude people that are not. Sometimes it just falls out of my mouth because I'm so steeped in that world. But really so nursing researchers have been studying this for decades because of the shortage of nurses and needing to figure out how do we make a case for taking care of our workforce, because nurse researchers have identified that the way to keep a stable workforce is through provider well-being. And in the last 5 years, we've seen more of a surge of literature around physicians that's aimed at achieving the same goal. I'm going to give you some examples from the literature that's mostly around, most of the literature at this point is really around RNs and some around physicians. And there's less around advanced practice nurses, but I will point it out when we're in the places that there is some available. So I'm getting an echo. Okay, thanks. So there's an association, Tawfiq and colleagues found that physicians who are experiencing symptoms of burnout were over twice as likely to report medical errors. Dr. Rebecca Clark and her colleagues found that 84.5% of maternity nurses with burnout symptoms were reported missing care, and that missing any care, compared to only 56.4% of maternity nurses who are not burned out in that same sample. And over half of those who reported symptoms of burnout reported not comforting their patients or talking with their patients during their last.
I'm very sorry, Brie. Could somebody mute? There is somebody who is not muted. If we could all mute, that would be great. Thank you.
It's not a problem at all. It happens to all of us all the time. Dr. Simiotti, she did some really amazing seminal work at hospital levels, looking at the rate of burnout amongst the entire nursing staff in a hospital, and found there was an association between the rate of nurse burnout at the hospital level and hospital-acquired infections. And she and her team were also able to show that when hospitals were able to reduce burnout by 30%, they had 6,000, in this particular study, 6,239 fewer infections and saved $68 million by just reducing burnout by 30%. Another great example that's a little more recent, Panagiotti, in studying physician burnout, found a twofold increase in physicians reporting unsafe care. Amongst those physicians that reported experiencing burnout, they had a twice-fold increase of reporting that their care part of their care had been unsafe. And then also burnout is associated with workforce instability, like absenteeism and turnover. And the reason I have it there sort of next to the cost of care is that it's incredibly expensive for organizations to hire and orient staff. Robert Wood Johnson Foundation, they estimate that for new nurses, for RNs, it costs between $22,000 and over $64,000 to hire a new person. So the effect of burnout and people leaving can have huge effects on the bottom line. And Lazinger and Fida, they did a lot of work in Canadian nurses, and along with many other researchers all over the world, have found a strong relationship between provider well-being and people either leaving their positions or leaving their profession altogether. Also, more recently, Derby reported higher rates of absenteeism amongst nurses experiencing burnout. And then also provider burnout is associated with patient satisfaction. And I don't love the term complaints, but provider burnout is associated with a higher rate of patient and family complaints. And physician burnout is associated with higher rates of patient dissatisfaction scores. And there's also some emerging really compelling evidence around providers that are experiencing burnout having higher rates of implicit bias. And that work was done in residence also by Derby. And that implicit bias affects every aspect of care. And so that is really just an important piece of this. So well-being of providers really affects all three elements of that original triple aim. And it won't surprise any of you that all of these outcomes are also interrelated. That when you have more staff turnover, you also are going to have more adverse outcomes. It erodes teamwork and collaboration, interprofessional collaboration, and that also that outcomes are going to affect patient experience. And something that I didn't really focus on in this drawing that I was doing, because there's already enough arrows. But there's also this piece of when providers are the cyclical piece of when providers are experiencing adverse outcomes, when providers are experiencing turnover and absenteeism for the stayers that are still there, when providers are experiencing dissatisfaction in the people they're caring for, that also adversely affects their well-being. So it becomes the cyclical kind of perfect storm. And I think that's also what we're seeing a lot right now in the last year or two, when we need to figure out how to get out of this cycle that's affecting provider well-being. And this is to say the last couple of years that the COVID pandemic has really shed a light on what happens when providers are not taken care of, and then the cyclical nature. A couple months ago, the U.S. Surgeon General, Vivek Murthy, put out an advisory around healthcare provider burnout and how it affects our health as a nation. And I've even heard provider burnout as an issue referred to as a national security threat. So people are starting to realize that this has profound effects on our health as a nation, as well as our health as healthcare providers. So I want to talk more specifically about burnout. And I want to start by kind of arriving at a common definition. It's sort of like labor, that if you don't have a common definition of what constitutes being in labor, it's hard to have a meaningful conversation about it. And the term burnout is thrown around a lot. It's been around since the 60s in pop culture. It gets used as a noun and a verb and an adjective. And Bob Dylan used it as a past participle. But for the sake of this conversation and for when we're talking about research around burnout, these are the two most commonly used definitions. Burnout is a workplace syndrome characterized by high emotional exhaustion, high depersonalization, also known as cynicism, and a low sense of personal accomplishment. And that definition is from the National Academies of Science, Engineering, and Medicine. The second definition, a psychological condition in which an individual responds to chronic professional stressors with those same hallmark symptoms. What I really want to point out in these definitions is that they're related to workplace and professional stressors, and that burnout is considered chronic. It's not a matter of having a rough day or even a rough week. It's that chronicity of experiencing these work environments day in and day out for an extended period of time. And part of why I wanted to talk about exactly what burnout is that there are a lot of conditions that affect healthcare providers that look and feel a lot like burnout, but have different etiologies. And to use another women's health analogy, because again, that's kind of where I go. But it's kind of like pelvic pain, that you can have the same symptoms, but it can be pelvic inflammatory disease, it can be an ectopic pregnancy, it can be gas. And in order to effectively treat it, it's really important that we're able to identify what exactly it is that's causing us to feel, whether it's depleted or resentful of our work or exhausted. So I want to talk for a few minutes about these different conditions that affect healthcare providers. Now, compassion fatigue is probably the one most frequently used synonymously with burnout. And it's different because it's really about the interaction between patients, whereas burnout is about general workplace stressors that, there's lots of literature around people that work in call centers and burnout. Compassion fatigue is really about that provider-patient interaction. And it's, and to some degree, it's considered, an occupational hazard because it is in our job description to care for others. And it also, like burnout, it's a chronic condition. It's not something that happens overnight. And that it's caused by this imbalance between giving and receiving, or emptying and then filling back up again. The next one I want to talk about is moral distress. And more recently, people have used the term moral injury, which is defined as having experienced chronic exposure to moral distress. But moral distress is when a person is aware of a moral problem, acknowledges moral responsibility, and makes a moral judgment about the correct action, yet as a result of the real or perceived constraints, participates in perceived moral wrongdoings. An example of this that I've experienced is in an outpatient setting when I've believed that a specific drug is the best drug for a patient, but it's not on formulary. And so because of the constraints of the insurer, I'm pushed to prescribe something that I don't feel like is actually the best medication for that particular patient. From the birthing world, another example is when you're having a patient where you might have, a category 2 fetal heart tracing. It doesn't, it's not great, but it's not terrible. You also know this person, how they're progressing, that they've got reserves, and a physician colleague comes in, looks at the strip and says, okay, we're going for a section. And you're not in a position to say, no, that is not the right thing for this person right now. And you have to participate in something you think is morally a wrongdoing. The next one that I want to talk about is vicarious trauma. And this is the response of persons who have witnessed or been subject to explicit knowledge of or had the responsibility to intervene in a seriously distressing or tragic event. It's different in that doesn't have that chronicity. It's more sudden. It's something that somebody hasn't experienced, and then, a few days, a week later, all is more suddenly having symptoms. Some of these symptoms that providers experience of fatigue and exhaustion and feeling isolated. And then also post-traumatic stress disorder. And this is the DSM-5 diagnosis. And it's the exposure to actual or threatened death, serious injury, or sexual violence. And this can be very close to vicarious trauma. And the difference can really be about proximity to the traumatic event, and also about how one feels about the traumatic event can also determine which one it meets criteria for. But this is also one that tends to be more sudden, related to a certain event, as opposed to the chronic nature of some of the other conditions. And then finally, racial battle fatigue is a phenomenon that occurs as the result of constant physiological, psychological, cultural, and emotional coping with racial microaggressions in less than ideal and racially hostile or unsupportive environments. And I want to acknowledge that as a white woman, I have not experienced this, but I think it's really important that as a profession within nursing, we keep this at the forefront, especially because it's so important that we are building and diversifying our workforce and spending more time than has historically been spent talking about this topic. I think is a priority for us as a profession. So just coming back to this idea of these differential diagnoses and how we sort of triage ourselves. Differently than my analogy of the pelvic pain, these conditions actually don't exist in isolation. It's very rare. Usually it's some constellation of these different conditions that providers experience. There's a lot of overlap between them, and understanding the role that each of them is playing and how you're feeling can really help develop your own strategies to cope. An example that we see a lot in healthcare is that people will mistake burnout for compassion fatigue. And their strategy is to try to move into administration, to move away from patient care, which actually moves them closer to some of the administrative dysfunction that leads to burnout. And it wasn't really their patient care that was causing them to feel the distress they were. So kind of thinking about, for your toolbox as providers, how you can, again, sort of triage yourself and working with each other to help you work through the different experiences that you have as providers. And I actually realize now, as I kept referring to the symptoms, I should have moved the slide to the beginning, but these are some of the hallmark symptoms of burnout. They're also the hallmark symptoms of many of the other conditions that I was talking about. It's inability to concentrate, sleeping too much or sleeping too little, eating too much or eating too little, feeling detached, isolation, feeling irritable. And they do frequently look like each other. And it can be really hard to kind of tease out what a person is experiencing. And I like this. I think this quote really captures the experience of being burned out. First, I felt like a pod person. Every activity of every day was just a mindless process of going through the motions, the minimal amount of activity just to get through, from getting up to showering to getting dressed, getting to work, and then being at work. Just rote motion after rote motion after rote motion. I just felt like my motor completely died. I had zero reserve, and yet I just kept going, kept pushing, even though I couldn't really think. I felt dead. So no conversation is about burnout is complete without talking about resilience. And I wanted to first, and I'd asked Anne that I think all of you have access to your chats. So I'm curious what some of you sort of think of when you think of the term resilience. If you just want to drop them into the chat. So I'll just start reading them. Strength, being able to go on, bounce back, being able to keep going, a person that does not give up or quit, a survivor, pushing through sometimes. These are great. Thank you all. Yeah, thank you. Persistence, strength. Thanks. So let me give you, this is the definition from the National Academy of Science, Engineering, and Medicine from 2019. And I think what was interesting is that in most of the definitions that you, the words that you put into the chat, tended to be kind of more characteristics about individual people. There is this notion, this idea that it's an organization or a community or a system. However, I will, I think it's important that resilience, we're careful not to use resilience to place blame on providers. And I really personally struggle with it. While it's so important to have, I also think we need to not let organizations weaponize the term resilience to blame providers and blame providers for their own personal failings. When we're talking about burnout, when you go back to those definitions, it was about workplace stressors. It was about what a work environment looks like. And while yes, we are individuals that need to go to work, we also need to think about, like, resilience is something that you need to summit Everest. Our colleagues who are working in places where they lack for personal safety, clean water, need resilience. And in my humble opinion, this is people that have heard me speak before know that this is my commentary, that in my humble opinion, we should not need resilience to manage working in hospitals in a high income country that has one of the highest per capita healthcare spending in the world. And that the onus really needs to be on organizations to create work environments that don't require that degree of resilience. And so while I do think it is very important, and I don't want to lose sight of it, I mean, it really came out of this idea, we don't want to be so negative about how we think about this. It's not just about burnout. And at the same time, I also want, as a body of healthcare providers, for us to hold our power, and that it's not our fault if we're experiencing burnout. And in just a couple slides, I'm going to show you some of the models that are used across professions and show empirically the relationship between individual characteristics and work characteristics when we're talking about burnout. So I'm going to talk again about the science of burnout, how it's studied, and then a little bit about my own research in the area. So as nurse scientists, we use models to guide our research, and so do organizational psychologists. And this is the job demands resource model, and it's used across disciplines throughout the world. And what it posits is that burnout is the consequence of high demands and low resources in a workplace. And importantly, the personal resources can buffer the effects of the demands, but it's not in and of itself responsible for burnout. And it absolutely breaks my heart when I talk to providers who blame themselves for their burnout. And I think a way to look at it is, we think of it like post-traumatic stress disorder. Post-traumatic stress disorder does not happen without a traumatic event. A person can be more prone to it, but without that traumatic event, you're not going to have PTSD. And so in the case of burnout, without the work stressors, without the work environment, you won't get burnout. So we need to keep going back to what is going on in the work environment. And so these are two lists of aspects of the work environment and some personal characteristics that have been empirically associated with burnout amongst nurses, nurse practitioners, and midwives. I use the term cause in quotes because most burnout literature is cross-sectional, so that we can't really establish causality. But we do know that people that experience higher degrees of burnout tend to report these different conditions in their work environments. So there's the correlation. So first, the relatively short list on the right of the personal characteristics, and then the very long list of the organizational characteristics. And while again, these personal characteristics can guide, who we really nurture and provide more attention to, these are not really the factors that a healthcare organization can affect, unless they want to pay for a dating app for everybody who's single, or I don't know, I guess they could pay for gyms. That would be good if they paid for healthcare gyms and yoga classes. And some are. But also, and then also we shouldn't limit who can become nurses, nurse practitioners, midwives based on whether they're at risk for burnout. What really matters is this list on the left, this much longer list that of the overwhelmingly organizational level factors that are driving burnout. And I'm going to walk through not too much statistics, but some from my own work to show you also just empirically how much more these organizational characteristics actually mathematically contribute to burnout. So given the role of the organizational and practice characteristics, it's important to distinguish these structural characteristics and from the practice climate. The structural characteristics, these are the pieces, these are the concrete characteristics. These are things like where a practice is located, who the patient population, things that are generally not very adjustable, very malleable. And then there's the practice climate, and these are perceptions of the work environment. Otherwise, so things like autonomy, control over one's work. And this is important because while we can't change the structural characteristics, there is a lot of room to change these perceptions, how supported people feel, whether they're getting the feedback that they need, whether they're practicing to their full scope of practice. And it's also interesting because sometimes you'll see that organizations will point to some of the structural characteristics and say, well, the reason that our providers are experiencing more burnout is because our patients are just sicker. And not saying, okay, really, when we look at some of the numbers, it's the perception of how people are feeling in their work environment that is driving their burnout more than any of the structural characteristics, the things that are not controllable. I'll briefly talk about some of my work and show you how these mathematically, how we see this pattern of what's causing burnout. In 2017, I conducted an online survey of the full American Midwifery Certification Board roster. So it was sent to around 12,000 midwives. This is the postcard that a lot of people got in the mail before, asking them to please open the email that they'd be getting. And there was a great response rate. Over 30% of all certified nurse midwives, certified midwives responded with a final sample size of 2,333, accounting for inclusion criteria and this data and such. So first, going back to this idea of these individual characteristics, these are the individual characteristics that I just did initially bivariate analysis to look at whether these individual characteristics were associated with burnout scores. I used the Maslach burnout inventory, which is the most commonly used measure of burnout amongst US providers. And you can see the age and years as a midwife are both negatively associated, meaning that the lower the age or the lower the number of years in practice, the higher the burnout. And this is consistent with other professions. The theory is that people who get burned out leave the profession. So when you look at people that have been in a profession for 30 years, they've stayed, and they've also found ways to cope or protect against burnout. Then the other individual characteristics that were associated with burnout were about how individuals worked. Shift work was actually this was very surprising to me. In this sample, people that worked nights had the lowest burnout rates, people that worked exclusively nights. And the highest rate was amongst those who flipped between nights and days. And I have my own theories about that if anybody wants to talk to me about, as a midwife who's worked nights for 20 years and still does. And then the other employment status, and that was more intuitive, that people that worked part-time or per diem reported less burnout than those working full-time. So then I looked at the structural characteristics. And you can see these are everything that's a yes were the ones that were statistically significantly associated with burnout scores. And the first two were really the patients per day and birth volume. Those are really indicators of workload. The next one was training of the decision maker. Midwives who reported that midwives were their primary decision maker reported lower burnout scores. And there were, with practice location, that was, it was really, there was only a difference between suburban and a mixed environment between suburban, rural, and urban. There was a difference between where people attended births. However, there were overall a lower number it was proportional to the population, but it was a lower number of people attending births at home. But people, in comparison to hospitals, people attending births at home reported lower burnout rates, but there was not a difference between birth centers and hospitals as far as burnout rate. And then the size of practice, people that were working in practices with only a handful of midwives tended to have higher burnout than those in very small practices with 1 or 2 midwives, or those in larger practices with 15 plus midwives. But this is the math magic that I like to talk about. So I took all these data and did a hierarchical linear regression model. And if you look at that first line, so first I put in all the personal characteristics from that first slide, and that accounted for only 1% of the variance in burnout scores. Then I added in all of those structural characteristics. Those were the pieces about, patient acuity, workload, those pieces. And that only accounted for 6.4% of the variance in burnout scores. And then in the last block, I added the practice climate, whether respondents felt supported, whether they felt like their practice supported the midwifery model of care, whether they felt like they had strong practice leadership, and whether they felt like they had participation within their organization. And that bumped up the explained variance from 6.4 to 26.5% of the variance explained in burnout. So that just gives you an idea of how large a role, how people perceive their support in their work environment affects how they feel as individuals and their burnout. So really, when we look for solutions, there really needs to be this piece of like, okay, how can we create work environments that have a culture and a climate where people feel supported and valued? I will quickly just talk about some of the limitations of burnout, not to discredit my work, but I want to make you all good consumers of this literature, and also for anybody who's interested in diving into it in their own work, in their own DNP projects, that a lot of the literature around burnout is dichotomized. It's saying you're burned out or you're not, because then you can get a really sexy odds ratio to say that people that were burned out had 2.5 the chances of a medical error. And anybody that's experienced burnout knows that it is a continuum, that you don't have one day you're burned out and the next day you're not. When your score goes from 25 to 27, you're suddenly burned out, that it is a continuum. And so when we study it, it's important to try to capture that. Most of the burnout literature is based on that first definition I gave you, and it's mostly measured by a single instrument. And so while there are all these other aspects of what's affecting our well-being, to go back to that last slide, only 26.4% of the variance was explained by burnout, which means that almost 75% wasn't explained. And so we need to continue to think about, okay, how else, using qualitative methods, using other concepts about self-efficacy, about how people are doing in their work environments, beyond just this idea of burnout. And they're much more advanced about this in Europe. Oh, okay, sorry, just came off mute. And then also that whenever you look at a burnout literature, you get a lot of response bias, because people that are really checked out, people that are really burned out, are not going to spend time opening up their work email and responding to surveys. And the flip side is you get people that are very burned out who are like, yes, I want to talk about this. So you do tend to get some response bias. And so again, these are just pieces that, as all of you, the literature is everywhere now. It's in all mainstream media. And so to help you all be good consumers of this, and also when you talk about it amongst yourselves. And how am I doing on time? Oh, I can see, sorry. I've got about 15 more,
I would say, in order to have a little time for some Q&A, maybe about 5 to 7 more minutes.
Done. Okay.
All right.
So, solutions. It's not about, it's not about bubble baths. It's not about a $5 Starbucks gift card once a year during Nurses Week. We need bigger solutions to this. And traditionally, burnout research has looked at organizational level interventions and individual level interventions, and they've been very siloed. A meta-analysis of interventions to treat physician burnout that was published in JAMA in 2017 found that, surprise, organizational level interventions had a larger effect, which makes sense because the causes of burnout are organizational. But unfortunately, the conclusion of that article was that that evidence does not support any firm practical interventions. What I propose is really unsiloing these two buckets, these two types of interventions, and looking at burnout prevention as a relationship between practices or organizations and the individual. And ideally, we'd all be able to find perfect employers that value APRNs, have authentic leadership, have excellent EHRs, and manageable patient loads. But this isn't always available, especially I know for people who are just entering the field. And so I propose that prevention can really be around managing expectations, compromise, and negotiations, because we enter into relationships with our employers. And just like an interpersonal relationship, it's really about figuring out, okay, what are the things that are most important to me? What are the things that I can absolutely manage and that I must have? And what are the things that I can step back on? The things that, like, they won't drive me as crazy. They won't affect me as negatively. So I can handle some of that because these are the things that I really need to have in place to keep going. And what really striving for that congruency. And this isn't a novel perspective. This is a framework by Leiter and Maslow that they propose that work-life mismatch is a primary cause of burnout in these different domains. Reward, and that can be salary. PTO can also be reward through recognition or career advancement. Control of your schedule. Community, how much social support you're getting in a workplace. Fairness, as you define it. The values of an organization versus your personal values. I have a colleague who works in a practice where their entire practice believes in having extended periods off, and they wrote it into the mission of their organization that they will each get 3 months off a year, and that's part of their values. And if that's a value to you, figuring out how to find it and naming it and looking specifically for practice settings that are consistent with those values. And when you're looking for positions, taking as much as you can, talking to people in the practice, asking them about what their work environment looks like, shadowing people if you can, see if they feel supported and valued, and having some really honest conversations with them and with yourself. And then also, just like romantic relationships, don't expect an organization to change. If you're interviewing and you talk to people and they say our workload is totally unmanageable, it's to see that at face value. And then another way to think about this is going back to that job demands resource model, that thinking about, okay, what are the resources that you need and what are the demands that you need and what are you able to manage? For example, you might say, okay, I cannot work nights, but I can work every weekend day. And that's something that you figure out ahead of time and that you go in and say, okay, this is what, or I can manage a really busy clinic load and I can see a lot of patients in a day, but I do not want to be responding to emails or taking call at home. So figuring out what those pieces are for yourself, what are your demands and your resources as you go through your career, and that knowing that they'll shift, that they're not static, they'll change. When I first started practicing, I wanted geography and I wanted full scope practice. And 2 years later, I decided that I needed a different schedule and that I really needed a mission driven. And so I completely changed jobs because I was like, okay, I need to be in a mission driven place that's consistent with my values for this time in my life. And that's, for me, has continued to change. And I think when you talk to some of your mentors, you can ask them how it's shifted for them over their lives as they've gone through different periods of their lives. And here's a few examples of different priorities to just really help you to think through what are the things that you really need in a workplace and where you can maybe negotiate a little bit so that you can find a place that that can meet your needs. And then I can't say enough about this, especially for those of you who are newer clinicians, that to setting boundaries, that inevitably we all care and we care too much and we give a lot of ourselves. And so setting boundaries clearly, graciously, and at the outset, you'll be a better clinician and a better person because of it. And finally, I just really want to end with empowering you all to do whatever you need to do, keeping in mind some of these things that I've talked about, but the most important thing is that you need to do what you need to do to be the best clinician that you can be, whatever that looks like to you, and to just keep working on it and to stick with it. Thank you. And I'll open it up for questions.
Thank you, Brie. That was really amazing. I'm wondering if you could stop screen sharing so we can just kind of all be in the meeting together. I'm going to let you catch your breath for a minute. I want to ask a question of our students. You don't have to go into a lot of detail, just a quick little blurb, but does anybody here have an example of how what you have been trying to do in your DNP project has been impacted by what you perceive as the burnout level of the team you're trying to lead? I'm just curious if anybody, if that rings true for anybody who's maybe implementing or now in their dissemination.
Planning where you don't, I'm sorry, like I'm planning. So in terms of like no responses and emails and some team members not being interested, right? Or no, yeah, for sure. Yeah, not on the midwifery side, which I hate to, because the team's going to be the midwives that I work with. But I've tried to, one provider will, but physician, but nobody else responded to some of the emails I sent out. Okay.
Anybody have an example from who's now on the other side and now disseminating?
I'm disseminating, and last term during implementation, the team step scores that I did use were like, I want to say 35–40% improved just from the interactions and communications and things that we did by flattening out kind of like the structure. Instead of having it more hierarchical and top down, it was more so, a flattened, spread out web of communication where everybody felt like they had a say so and feedback, in which they did with the iterations that we were going through. I would take feedback from them and we would make changes. So the scores were way better. And they said the communication and everything was just like super. And we wish it could be like that every day in the system here.
That's great.
Yeah.
Anybody have any questions for Dr. Thumm, or want to comment or ask for more information about what's been presented here tonight?
Will we get a PowerPoint or something? I mean,
I've had a few people ask if slides are a possibility. Okay.
Definitely. And there are, the reference list is pretty extensive, and I can even put some more in. Yeah, it's a good resource if you're looking for some place to start.
yeah, for me, that organizational list and those things, that was I was kind of attaching to that.
I would like to pick her brain about something. So one of the organizations I work for, they're now offering double time to employees. And all of these employees are money hungry, and they're working 5 12-hour shifts. And there's all of this research about burnout and how it has all these poor outcomes. But the organization is pretty much promoting burnout because these people are just working and working and working. They have no life. Do you have any ideas of how I could bring this back to them and say, this is going to hurt the organization and our patients in the long run, because people are going to get burned out because they're just working way too much?
That's a great question, Joseph, because if you think about that, that model of work-life mismatch or congruency, there are people for whom, like, making all that money, they're like, I'll take it. I will do whatever I need to, and they will get through that, and they'll get the cash, they'll pay off their whatever, and they'll be okay. And then there's other people who won't. And so a lot of the piece is that it's not just, it's never about one piece of it. If they were forced to work, that's where you get this lack of control issue. So it's looking for what else on top of the, yes, you work, and yes, people need money, and yes, we have a system that systematically underpays people, nurses. That's another talk. I'm welcome to come back. But I think that it is accurate. It's also thinking about that constellation of things that individuals need. And that some people need more recovery time. Some people are like, I will trade money for autonomy any day. That is my and it is, I will not acknowledge that there's some privilege in that, but it's also like, I need autonomy. Otherwise I just fall apart.
Mm-hmm.
But for everybody, it's different.
I want to ask, there was a comment made in the chat that I think relates to this, and maybe Brie, you could speak to this briefly. Burnout isn't the same as being busy and working a lot, because I think there's a discussion going over here in the chat that for some people, they love a packed schedule. They thrive on being busy. They don't feel burned out, but for other people that would burn them out very fast. So can you speak a little to the difference? There's people over here in the chat saying, I think it's about the autonomy. And can you say a little more about that? Like whether you chose to be that busy versus not choosing, and kind of how that works.
No, it is. There's, you'll see it referred to as control of work or autonomy. But it is this piece of people when they feel like they have a choice, regardless of what that choice is. I mean, I have a 3-year-old, and I hate to say this, but so much of what I know about what I learned in the last like many years about burnout applies to my toddler. I'm like, oh, you just want the perception of choice. And it is very true though, of like figuring out like how organizations give people that autonomy, whatever that looks like. They need to be able to figure out ways, whether it's how they build their staff, so people have choices. Because that piece, and that's actually a really in the midwifery world, there's this continuity of care model where, and it's done around the world, and midwives work so much more when they're doing it, but they also have very little supervision in most of the models. And they also get to spend a lot of time one-on-one with patients. And so despite the fact that they're all working a lot more hour for hour, they're actually report less burnout because they have this autonomy and these relationships with patients, which for midwives are protective over the workload. Is that helpful, Anne?
Yeah, no, I think that really gets the point across, because I don't think we want to equal burnout with being really busy, because not every,
And it
we're all really
varies
different.
for people throughout their careers. That what might feel totally manageable to you during one part of your career, where like the most important thing is to have a down payment on your house, and you will work all the time. And then fast forward 3 years and you have a sick friend, family member that you want to have time with, and you do not want to work more hours, and it doesn't matter how many, that time is priceless. And so it will shift, and being able to figure out ways that you can make your career work for you and shift it, and the communicating that with employers to say, okay, this is what I need right now. I will stay here because it costs you this much to find somebody new. I'll stay here if you work with me on this, because this is what I need now. And when you all become managers, bringing all this forward into your management.
There was a good question. I mean, so I'm not sure, but one person just said, I keep wondering about the client or patient. Are we sure our patients are safe? Are we sure that working many hours also makes for good decision making? So it just goes back to that safety question too.
Yeah. And that's about sleep and safety. And there's a whole body of literature about people working too much. And the residents, a lot of it came from the resident world, because with residents starting to cap their number of hours because it wasn't safe.
It may seem strange, but if I could add, it seems as if it kind of mimics in a way like drug addiction. There's a physical aspect, but there's also a psychological aspect. So like when you speak to, the environment at work, that's like more psychological, and it had the biggest effect on variation. So when you have that physical aspect mixed with that psychological aspect, like as if drug addiction, would cause on someone, that's when it becomes something that makes it not functional. And with Joseph's question, and I kind of thought about the COVID epidemic, like, we had nursing shortages, of course, before that, but of course, we all know, I'm sure some advanced practice nurses went back into RN because people kept trying to tempt me to come to chase that money. When you were getting $10,000, $13,000 per week to do this and to do that. But then if you look in the aftermath of that 2.5-year period, I know some personally who worked 6-7 months, paid off their house or whatnot, but my God, we're just totally worn out mentally and physically. And now if we look at the aftermath, is kind of telling.
So I want to be mindful of, speaking of boundaries, I want to be mindful of our time. We have come to the end of our hour. Dr. Gianellis has been putting some very relevant notes in the chat for those of you, especially who are in PC 740. You're doing team surveys and team assessments right now as you plan your project. So if you're having a very high level of burnout and dissatisfaction, you need to be thinking of that as a gap as you plan your project. And same way when you're implementing, it's very hard to get teams to adopt new evidence-based anything when they're feeling already pretty detached in the workplace. I don't think we intended to solve burnout tonight, but I think, Brie, you gave us really a wonderful overview and a lot to think about. And very grateful for your time tonight. Thank you. Thank you. Thank you.
Thank you all so much for everything that you do. Seriously, it's so hard being a student. It is such hard work making those role transitions. So just thank you for everything you're doing and for being here.
Yeah. And I'm so glad everyone was able to be here tonight. If you need to document the end of your presentation before the Zoom ends, please make sure to do so. And best of luck. Make sure you upload this if you need to document it for one of your classes. And Brie, I am thankful for your presence here tonight. Thanks again, and I will see you soon. Good night, everybody.
Good night.